I believe this is in no small measure a testament to the significant impact that Dr. Alakija had during her lifetime. Not just her personal impact as a wonderful human being and a child of the Most High God, but also her professional impact as an excellent doctor with a far-reaching vision for the practice of medicine in Nigeria. DFAF was set up to continue Dr. Alakija's life work and to promote her vision of contributing towards the development of a Nigerian healthcare system comparable with that of any developed country. I encourage you to visit our website for details of the pillars we intend to employ to realize this vision. One of the pillars is providing education, counseling, and mentorship in our schools and our communities, and today's event falls under that pillar. Our inaugural lecture last year had us all glued to our seats, as Professor Akin Abayomi, who is now Honorable Commissioner for Health in Lagos State and one of our panelists today, took us on a fascinating journey on the Understanding the New Age of Genomic Strain. This year's lecture is titled Sickle Cell Disease, The Future is Bright, and it continues the theme that Professor Abayomi started last year, that of exposing us to breakthroughs in medical science and also exploring how these breakthroughs can be practicalized in Nigeria. Now, today's lecture was initially to have taken place in April, but then the pandemic struck and we had to postpone the face-to-face event. We then decided to have a virtual event and we rescheduled it for today, only for us to find out a few days ago that September is actually Sickle Cell Awareness Month. The perfection of the timing of today's event could only have been God. I know this lecture will be highly informative and equip us with valuable knowledge that we can share widely. And for our medical colleagues, knowledge that you can apply to your patient care and medical research work. Now, I've known the keynote speaker, Dr. Modupe Elebute, for 45 years. She's a distinguished and highly regarded hematologist, and I can't wait to listen to her lecture. We also have a great panel, Professor Akin Abayomi, who will be joining us, and it's good that he's still able to join us despite his recent COVID diagnosis. I'd like to thank him for the great work he's been doing in Lagos State, and also thank God that he has now tested negative, and we pray for his full recovery. We also have Dr. Annette Akinshete, who is at the forefront of sickle cell advocacy in Nigeria, and the panelist who is perhaps dearest to my heart, Ms. Igi Aihomu, a young lady who is a true warrior and has a wonderful personal testimony to share. I trust God that the collective discourse this afternoon would lead to tangible transformation in the care and treatment options available for sickle cell warriors in Nigeria. I will close by saying that at DFAF, we will continue to pursue activities in line with our vision. And we invite you to join us on this journey in whatever capacity you feel led to, either by donating, which you can do via our website, or perhaps even joining us on one of our outreaches, post-COVID, of course, as we work to improve access to primary healthcare services in Nigeria for all. So please sit back and prepare to be challenged, excited, and inspired. Thank you for your time, and God bless you. I will now hand the virtual microphone back to our moderator, Dr. Funmi Alakija Adepoju. Thank you.
Thank you, Mrs. Ayeni. I will now call on Alera to pay tribute to our late mother, Dr. Funmi Alakija, and also provide an overview of DFAF and what has been done to date. Alera.
Good afternoon, distinguished ladies and gentlemen. My name is Alera Alakija, and I'm the first daughter of the late Dr. Miss Funmi Alakija, in whose honor we have all convened here today. It has been just over 2 years since we lost our mom, and as the months and years go by, I grow to have a deeper appreciation for my mom and the exemplary life she lived. Her life is honestly a reminder to me of the importance of living a full life in Christ. My mother excelled in all things, from being a wife, a mother, a daughter, a sibling, a friend, an employer, and many more roles she held. Whenever my mom stepped into the room, She made a difference. Mediocrity was not in her vocab. And she strives to bring out the best in everyone around her. When I think of her life, I think of a life well lived and one that glorified our Father in heaven. Her legacy is undeniable to anyone that knew her, and it can be seen clearly in the clinic she set up. Q-Life Family Clinic. Providing quality healthcare in Nigeria is something she was passionate about and dedicated the majority of her life to. My father, wanting to honor and keep our mom's memory alive, came up with the idea to set up a foundation that will continue her life's mission of improving primary healthcare services in Nigeria that will compete with global standards. The Dr. Funmi Alakija Foundation, also formally referred to as DFAF, was established in September 2018 and is led by an incorporated board of trustees consisting of family and friends of Dr. Funmi Alakija. The foundation was formed to continue her work and ideas, especially in the area of medical care for the less privileged. DFAF was set up to fulfill 8 key objectives, which include, but are not limited to, providing suggestions that enhance medical care across the country, advocating for improved medical performance in Nigeria, directly meeting the medical needs of disadvantaged people and groups across Nigeria, providing education, counsel, and mentorship in our schools and communities, and helping to establish and allocate health centers and facilities that ensure the foundation's objectives are carried out successfully. Since the inception of the foundation, we have organized 2 medical outreaches at the community, expressly, and an inaugural medical lecture. The inaugural lecture took place on the 18th of April 2019, and our key speaker was the esteemed Lagos State Health Commissioner, Professor Akina, where he gave an engaging lecture on the importance of genomics and its role in helping advance science of medicine globally. The outreaches took place in partnership with Destiny Trust at the Resource for Advocacy in Lagos. We provided free healthcare services to approximately 500 children and mothers living in the estate. Some of the issues that were identified and addressed during the outreach missions were poor personal hygiene, malaria, and various infections. DFAF provided provided medical care and medications to children and others in the community. The overwhelming response from gratitude was touching and further ignited the team's dedication to the mission. Thanks for supporting us during the last 2 years. DFAF plans to do more medical outreaches in the coming years and to do updates to improve the overall health landscape in our community. It is also our intention to collaborate with Lagos State on some projects in the future. I will close by saying today's topic is one that is close to my heart. I'm one of many Nigerians living with sickle disease. By God's grace, I've had it relatively easy. I've been blessed with health and also parents who weren't just devoted to looking after me, but who are also both medical doctors. And so I also receive the best medical care. But I know that many Nigerians living with sickle cell disease have a much harder time. And I pray that as a result of today's event, we'll be able to make it easier for many sickle cell warriors. So I hope you enjoy the rest of the session. I'm really looking forward to it, and have a nice day.
Thank you, Alara, for the lovely tribute, and thank you for sharing your story with all of us. The keynote lecture is about to start, but before I introduce our keynote speaker, I would like to ask you to type your questions in the question and answer box, and they will be addressed during the question and answer session. It is now my pleasure to introduce our keynote speaker, Dr. Modupe Elebute. After Dr. Elebute qualified in medicine from the Lagos University Teaching Hospital in 1986, she completed her postgraduate training in medicine and hematology at Centers of Excellence in London, including St. Bartholomew's Hospital, St. George's Hospital, and the Royal Marsden. Dr. Elebute also received a prestigious Leukemia Research Fellowship and gained a Doctor of Medicine degree from the University of London for her groundbreaking work. In the UK, Dr. Elebute has held consultant and honorary senior lecturer posts at St. George's Hospital and Medical School, the UK National Blood Transfusion Service, and King's College Hospital, and has a well-established private practice at the Spire and Leicester hospitals. Dr. Elebute was involved in the development of the undergraduate hematology curriculum at St. George's University of London, and was a postgraduate director and educational supervisor for University of London's hematology postgraduate training program for several years. In Nigeria, she has worked at the Lagoon Hospitals, where she was instrumental in developing the pathology laboratory and sickle cell clinics. She has a passion for research, and she has been principal investigator for clinical trials and a large study in blood transfusion funded by a £1.8 million grant from the UK Department of Health. Dr. Elebute is widely published in scientific journals and textbooks. She's a fellow of the Royal College of Physicians and the Royal College of Pathologists, and a member of the British and American Societies of Hematology. Passionate about giving back, Dr. Elebute helped to set up the Sickle Cell Club of Lagos while still in medical school. She is patron of Build Africa and past trustee of the Walkabout Foundation. She's also married with children. I will now hand over to Dr. Modupe Elebute for her keynote lecture.
Hello, good afternoon. Can you hear me? Excellent.
Yes,
thank you. Perfect. Thank you so very much for that very kind introduction. And in particular, thank you very much for the very kind invitation to give the second annual keynote address at Dr. Funmi Alakija's foundation. I feel really honored, I feel really privileged. I mean, although I did not get to meet Dr. Alakija, I obviously have since heard a lot about her and really value her, the work that she's done, mostly in family medicine, and as also the fact that the foundation has made up its mind to continue to drive a number of medical interventions, both from a primary care level straight through to research, as was seen in last year's inaugural lecture by the Honorable Commissioner for Health. I do feel that I'm walking into big shoes today, but I'm going to do my best to live up to the expectation. And what I'd like to do today, because I realize that we are talking to a mixed audience of both patients and their families, of medical colleagues, and essentially of family and friends to the foundation. So I'm going to try and take you through a journey in a condition that has been well described for many years, but as most of us know, has not had the privilege of exciting new therapeutic interventions until the very last decade. However, I am pleased to say that yes, the last decade has been incredible in terms of the conversion of the knowledge in sickle cell into the practice and the therapeutic strategies that now lay ahead for patients, which is just excellent. So I'm going to now share my screen and switch on my slides. Brilliant. So this is the outline of my talk, and moving very quickly on to say that actually sickle cell was first described in the very, very late 18th to 19th century, and the beginning of the 19th century was when it was described a bit more. In fact, the first patient was a dental student who was practicing in the US and who had presented with anemia that kept coming back, as well as leg ulcers. And eventually, a student of an eminent professor of medicine, J.B. Herrick, described that when he looked down the microscope, he saw some abnormal blood cells in this young doctor's blood film. It took another 20 years or so for it to be seen that actually the cells became that shape only when the patient lacked oxygen, or in particular situations, which we all now know can be well described. So patients, when they have infections, when they're dehydrated, when they're feeling unwell, is when actually mostly a lot of these cells actually sickle. And then later on, there was further work done into the molecular structure of the condition, and which has led to us understanding a bit more about its biology. And as I said, because I know I'm talking to a wide audience, some of people who may not be medical, what is sickle cell? Sickle cell is a condition of the red blood cells. And this is the red blood cell here on the right-hand side, which I hope you can see my arrow, which has a membrane around it, and it's a biconcave disc. And that's very important because we need to understand that this is how these cells travel through the blood vessels, changing their shape as they swim along, but maintaining this biconcave structure. The red blood cell also has hemoglobin and a heme molecule which contains iron, and the main job of the red blood cell is to transfer oxygen around the body. Now, there are a number of red blood cell disorders, and I think this is very important to discuss at this point, because as we will see going through the talk, and as I'm sure most people know, anyone who knows a patient with sickle cell disease, one of the biggest issues remains the stigma that's associated with the condition. So it's not the only red blood cell disorder that can be had, and most of them are inherited. In fact, this is a picture of a normal blood film. The majority of the cells in this blood film are red blood cells, with the concave disc is what gives you the pale bit in the middle there. The other cells that you can see are white blood cells and platelets, and we will not be discussing that for today's lecture. Now, this is a blood film which I came across when I was a medical registrar at St. Bartholomew's Hospital in London. This is not sickle cell. These cells are clearly not round like in the previous one. In fact, they're more elongated, or what we call elliptocytes. So this condition is called hereditary elliptocytosis, another of the red blood cell disorders that can be inherited, this time something that happens because there's a problem with the membrane of the red blood cell. This blood film is actually a blood film from my father, who, when he presented to St. Bartholomew's Hospital many years ago in his 50s for investigations for something completely different, was when we found out that actually there was a history of this dominant red cell disorder in the family. Fortunately, it didn't cause him much problem during the course of his lifetime, and he remained fully functional as a very eminent and very hardworking surgeon, one of my greatest mentors. But that's just a point to make about the fact that, you know, there are many red blood cell disorders. Obviously, for the rest of this talk, we're talking about disorders of hemoglobin, and in particular of sickle cell disease. So with hemoglobin, the normal hemoglobin, we have hemoglobin A, which has 2 alpha and 2 beta globin genes. The fetal hemoglobin, which comes before, and you can see in the graph here that when everyone is first born, we make fetal hemoglobin, which is this one, the green line here. And after about 6 to 9 months, the amount of fetal hemoglobin we have drops off, and normal adult hemoglobin takes up the role of providing red cells, taking oxygen around the body. What is sickle cell disease then? Sickle cell disease is a genetic disorder in which there is a mutation in a point of the hemoglobin B gene. The hemoglobin B gene is responsible for making that beta chain. So I said 2 alpha, 2 betas, and this is a mutation in one of the hemoglobin B genes that occurs at the time when genesis is happening and when a baby is being made. Now we know that hemoglobin B gene, or HBB, occurs on chromosome 11 in the body at location 15 on that chromosome. And this condition is just due to just 1 point mutation. It's called a single nucleotide polymorphism of this HBB gene that occurs at that time. That's all, but we've known about it for quite a long time. And actually it's helped us to understand the molecular basis of quite a number of conditions that occur. But this point mutation in HBB gene results in a mutation in the DNA from the normal person, from GAG to GTG, and is responsible then for the, I don't know where that went, sorry, for the change of the protein from a normal protein, glutamine, to valine, also in that hemoglobin. And this is what happens. So hemoglobin, the normal hemoglobin with 2 alpha, 2 beta, ends up with a mutation in the beta gene, and that transformation with the glutamine to valine causes this change in the shape of the normal red cells. So normal red blood cell film again, normal peripheral blood smear again, with normal biconcave red cells, a few white cells and platelets. And this time we're not showing you elliptocytes, I'm showing you a film which shows quite a significant number of sickle cells. And we'll go a bit into this a bit later, into why this is important and what it causes in patients to cause the problems that we see from a clinical point of view when we see patients in clinic. So sickle cell is one of a number of red blood cell disorders, more of a hemoglobin problem, not a membrane one, but it's also an inherited disorder, as most of us know. And this slide shows the inheritance in sickle cell. So 1 normal and 1 abnormal gene with the hemoglobin B gene has been changed in both parents, which results in the transfer of these genes in a number of patterns to the children that they can have. Now, the one point I would like to make here, because when you're talking to patients and families, there is an understanding that, oh, the chance of having a child with sickle from this couple who both have AS is 25%, as in 1 in 4 of the children might have sickle. And actually, that's not the case. It's 25% chance in each child. So for every child that they have, there's a 25% chance that that child may have the SS gene or sickle cell disease. And so in some families, there might be a situation whereby the majority of their children are AS, but in some families, even if they have 2 or 3 children, they could all have SS or sickle cell disease. So that's just a message to make sure that people understand. Now, obviously, it's very interesting to be talking about this, but actually it's very important that we should be talking about this because, as you can see from this world map, we have the greatest population of patients with sickle cell disease in our continent. And in particular, because obviously Nigeria is a very populous country, we have probably the highest number of patients with sickle cell in Nigeria. And then one question I always get asked is why? Why is it that sickle cell is mostly in Africa and not in Europe, for example? And this answer to that question is on the next couple of slides. There is a relationship between sickle cell disease and malaria. So in the map on the left side, this shows you where sickle cell occurs, the percentage or the incidence of sickle cell gene occurring. And in particular, as I said, you can see in West Africa and just below, we have the highest incidence of the allele or the gene. And if you look at the mirrored map on the right-hand side, you can see that actually in that same areas, malaria, falciparum malaria in particular, was endemic and has been and continues to be endemic in these areas geographically, whereas it's not in most of Europe and in Asia. And the reason for the association is that, yes, mosquitoes carry falciparum malaria, and they go into the blood and they infect the red blood cell, that biconcave gene cell that I showed you earlier on. And when they get in, they reproduce and they increase in number, and eventually they burst the red cells, and the malaria parasite affects the person and the patient becomes quite unwell. Now, what has been shown very clearly now is that with the sickle cells, the different shape of the sickle and the fact that it's quite rigid because it forms from polymers, it's very much more difficult for the malaria parasite to infect the red cells. Also, the sickle cells that have been affected have a shorter lifespan than the normal red cell. Normal red cells live in the body for up to about 3 months. With sickle, most of them die within about 2, 3, 4 weeks. Therefore, people who carry the trait for sickle, as you can imagine, are protected against the malaria parasite. So if you think about that scenario, we're protected from dying from malaria. We have a high incidence of our population. Therefore, we have a high incidence of the gene and quite a lot of patients, therefore, either can end up with the risk of having sickle. So how do we diagnose sickle? Obviously, the patient tends to be anemic, because I've told you about the shortened red cell lifespan. We looked at the blood films already. I'm sure that most of you can now look at the red blood film and tell me whether it's elliptocytosis or sickle. It's one of the fun reasons why I went into hematology, because we can sit in the lab and we can make the diagnosis of most of the conditions that we then end up treating patients in the clinic, which makes it really exciting. However, there are other also more definitive tests, the sickle solubility test, where all we do is reduce the oxygen in the tube, or put a reducing agent, and it makes the cells sickle and the blood becomes turbid compared to the normal blood, which is clear. But the definitive test is hemoglobin electrophoresis, where we put a gel on a protein gel, and we with electricity, the different hemoglobins move at a different pace, and you end up with hemoglobin A and A2 and S at the top. So this patient here only has S and no A, and that's how you make a diagnosis of sickle here. So I've talked about sickle cell disease in the broad term, and this is just to illustrate that there are other hemoglobin abnormalities that can be inherited, either on their own or together with S. So yes, the majority of the patients that we'll be talking about for the rest of this conversation are patients with HBSS, but there are also patients with HBSC, S-beta thalassemia, and so on. And this is important to note because the severity of sickle cell disease varies widely amongst patients. Alero has very kindly shared with us the fact that she's had quite a mild phenotype, which is great. One of my greatest friends in medical school, excuse me, she only found out when she was in her 4th year in medical school that she had sickle cell. She'd never been really unwell. And if you say that to another mother who comes to clinic, where her child has had problems with sickle since they were 6 months old, then, you know, how do you explain this diverse clinical phenotype, or the way patients present? This is still one of the big issues for us to try and find out about when we manage patients. Why does one patient not have so many problems, whereas another one is in hospital all the time? How do patients with sickle cell present? Now, I showed you the normal biconcave cells, which are swimming nicely in blood vessels. And these are the sickle cells, or which have now become stiff and have an abnormal shape and actually are unable to travel as smoothly through the peripheral blood and blood vessels. And this causes a number of issues for the patient. I've talked about the fact that the red cells, therefore, are disrupted and taken out of the body earlier because they are of a different shape from what the body recognizes as normal, and therefore these patients are chronically anemic, which is an issue in itself. Everybody that talks about sickle or understands sickle always knows about the very painful crisis, which is caused by the fact that these red cells stick in the blood vessels, cannot move on, therefore cannot carry oxygen to different parts of the body. And if you can't carry oxygen, for example, to your brain, you're potentially at risk of having a stroke. The same happens in other parts of the body, but for the rest of this conversation, I just want to talk about the more serious complications that we see in sickle. So stroke is a major issue. Acute chest syndrome or sickle lung is another one. And also, we talked about the painful crisis. That's not to say that sickle ulcers, when they happen, are not a major problem. Osteomyelitis, which is an infection in the bone, which can cause significant problems. And of course, other end organ damage, particularly with the kidneys and with the eyes, all cause significant impact on patients. And as I said earlier, though, there is quite a wide variety in the way that patients develop these complications, and some of them may not actually have any at all. A picture from a child who, at that time when they were changing from fetal hemoglobin to adult hemoglobin and developed the SS instead of normal adult hemoglobin, presents with these swollen, painful fingers and sometimes in the feet as well, a condition termed dactylitis, which was described in the very, very late 80s, 90s in children with hemoglobin SS. One of the other worries that we have is of acute chest syndrome. This on the left-hand side is a normal chest X-ray with without any problems whatsoever, and on the right-hand side, very clearly you can see some infiltration in the base of the left lung. This sort of sign in a patient with sickle is particularly worrying because this condition can quickly deteriorate in such a way that patients are unable to breathe and become very unwell, and this has to be managed as a medical emergency. Studies have shown that patients who develop one acute chest syndrome, and certainly anyone who develops more than one in context of sickle cell disease, have a tendency to have a more shortened lifespan compared to patients who do not have acute chest syndrome. So it's something that we really need to be aware of. And also when we're talking about the new types of treatment that are available, particularly with hydroxycarbamide and transplantation that we will talk about shortly, these are the kind of patients who have already developed these complications who need to be considered for these sort of treatments because it marks a severe phenotype in these patients. Stroke in sickle is something that thankfully we hope we're seeing less of, because now we're more aware, just like with acute chest syndrome, about the fact that in these patients we need to act quickly, and we also need to not just manage the acute problem, but these are the patients where we have to have a conversation about considering the newer types of treatments that we may have to make sure that these conditions do not occur again. One of the big issues though with sickle patients is that there is something called silent strokes, where the patient doesn't actually present with stroke as we know it, as in weak left side or right side of the body or headaches or anything. It's something that we only find when we do investigations in these patients, and there's a special investigation that's called the transcranial Doppler screen that will show up these silent strokes. Luckily, we do have this sort of investigation, unfortunately not everywhere in the world, but once we find patients who have silent strokes, and we know we've got to do something about them, because they are the ones who are at risk of stroke, further proper strokes and other issues later on. So that's looking at a patient who has a clear stroke because they have had a blood clot in the brain, because strokes can be either a bleed or a blood clot. But on the left-hand side, this is a patient who doesn't have any obvious evidence, and yet when we did the transcranial Doppler, it was very clear that there was an abnormal flow in the brain, which showed that the patient actually had already had a silent stroke. So this is one other complication of sickle, and the reason for mentioning it here is not because it's necessarily life-threatening like strokes or acute chest syndrome is in sickle. It's more about the conversation that patients do not tend to present with this condition until it's too late. And a lot of the time we find that it's because the patients feel ashamed because they have this sort of persistent erection of the penis, which is due to the red blood cells sticking in the blood vessels, just like I showed you in the earlier slides. Part of this issue has to do with the stigma and the fact that patients do not want to discuss all the issues that they have with this condition because they think they're going to be stigmatized against. There is obviously poor patient awareness also that this is due to their sickle, and so that needs to be something that we can hopefully try and educate patients about. And it is important because we have now seen that male patients, obviously with this problem, if the priapism lasts for more than 4 hours, they're at risk of getting, becoming impotent further on as they grow into adulthood. So it's something we really need to talk about. Now, I didn't think I could escape this talk without talking about COVID-19 and sickle cell. Mostly to say that, you know, the patients are like, you know, really at risk and need to make sure that they isolate and they take it quite seriously, but that they also build their immune system with folic acid and penicillin V and vitamins, and that their caregivers also make sure that they do not put themselves at risk so that they are not actually going to affect patients. Now, obviously, if symptoms develop and they worsen, the sickle cell patients do need to contact hospitals very quickly. If you think about the x-rays that I showed you earlier on, the medics in the room will say, well, there's no difference between what I described from COVID patients now without sickle. An x-ray with infiltrates in a patient with fever, with breathlessness. In today's day, one of the differential diagnoses will be COVID-19, and these patients should be tested. It is interesting, though, that there has been published a recent study from France where they collected all the information about patients who had been admitted to hospital with sickle cell disease in the last few months of the year. A total of 83 patients were described in the literature, most of them adults. 17 intensive care admissions, 9 of whom had to be ventilated. What is interesting though, is that actually normally HBSS tends to be more severe than HBSC phenotype, but in this particular group, and the numbers are small, so we can't really extrapolate too much, but it seemed to be the patients with HBSC who had more of a problem and required ITU admissions and ventilations. What is good to know is that it doesn't look overall like there was any increased risk over and above the population for sickle cell patients. But I do think that that's partly because the message has gone out very, very clearly and very early on. The patients who are at risk, so with immune suppressed problems, with sickle, with pregnancy, should stay at home and self-isolate. And I think that has helped, and that's something we should be talking about in the context of what's happening in Nigeria. So moving on to treatment options, there are a number of ways in which treatment can be targeted. I will like to emphasize what is found on this slide, that yes, there are a number of treatments that are available in sickle. There are a number of very exciting things that are going on, which we can discuss. But if you look very clearly, you will see that they change from the mortality of patients when they were around 10 years old. That was when I was in secondary school, in medical school, sickle patients did not live beyond age 5, age 10. And that change, that increase in survival was due to things like the Sickle Cell Act, which was legislation that patients should not be stigmatized about, and that employers should be careful about how making sure that these patients were not at risk of getting infections or being dehydrated and having time off when they needed it. Prophylactic penicillin has also made a big change because these patients are at risk of encapsulated bacteria. So prophylactic penicillin, vaccinations, before we even went into therapeutic advances with drugs or stem cell transplants, has made a significant improvement in the life expectancy of sickle. And I say that with emphasis because in our parts of the world where all these new treatments are not easily available, we need to remember that actually, even if we just maintain the basic treatments that we need to offer patients, it does make a difference in their lifespan. Also, earlier diagnosis has been found to improve survival. So that's something that really should be talked about. Having a national system of diagnosing patients earlier does make an impact in how long patients live. Otherwise, it's hydration, keeping warm, folic acid, because the red cells are being destroyed quickly, but with folic acid supplementation, you can help to produce more red cells. I've talked about penicillin and immunizations, and then obviously the management, more for the medics in the room, of treating the acute and painful crisis promptly when patients arrive in hospital, as well as providing blood transfusion for emergency situations such as acute stroke and acute chest syndrome. I do want to say though, that at the end of the day, I know we medics in the room think, you know, it's all about us, but actually in a number of chronic conditions such as sickle, this managing patients is teamwork. We need the nurses, we need the counselors, we need family members who tend to know the patients quite well, and their advice should be taken into consideration if we're going to manage patients properly. Apart from the therapeutic advances, which I will discuss in a minute, which I know that people are very interested in hearing about, I will also say that there is no doubt that the resurgence of guidelines on how to manage patients, which had been ignored for a very long time, and I want to pay tribute to a very good friend and colleague of mine, Dr. Adebayo Olujongbe, a sufferer himself, who did a lot of work in the UK to bring this to the table. And now we have guidelines which are now being rewritten in the modern day of medicine to make sure that patients do get access to treatment particularly for their painful episodes, promptly. The Sickle Cell Society in the UK has done a lot of work to produce standards which should be available to doctors in Nigeria and everywhere else, because they really are very good and they're very helpful. The American Society of Hematology has also done a lot of work in providing guidelines, and even now are doing them in a pocket size so you can carry them around in your pocket. So it's really exciting times for sickle, a condition that had been ignored for such a long time, a condition that showed a lot of patients in emergency rooms for a long period of time, not being attended to, not being understood, being stigmatized against. Now there is hope because there's clinical guidelines to help us look after these patients. So transfusions, I'm not going to belabor the point. I've said already, is more about treating this emergency situations, stroke and acute chest syndrome. So the patients having on a machine where the blood is taken out of their body and then replaced with normal red cells. So what happens is that at the end of the procedure, we've taken out a lot of the hemoglobin S and they have more hemoglobin A. And if you can get the S level down to below 30% with the exchange transfusion, then usually we can get patients out of these acute situations. So that was a patient with acute chest syndrome on exchange blood transfusions. Patients are not always that unwell when they come for the exchange blood transfusions, and I'm very grateful to this patient of mine who's a lawyer who came for his exchange blood transfusions because he had priapism, which was unresponsive to medical treatment. He's since gotten married and had 2 children, testament to the fact that these procedures do work and can help improve the life of patients. So coming to the more definitive therapeutic advances that we have, for a long time, there was nothing, and then the hydroxyurea came in the late 90s. And the main mechanism of action is that hydroxyurea increases hemoglobin F levels in patients. And we know that hemoglobin F, having more fetal hemoglobin in a patient with sickle, makes their phenotype milder. There are a number of other ways in which hydroxyurea works, reducing the white blood cells, reducing nitric oxide and the vaso-occlusion and adhesion that goes on. But that's a topic that can be debated for hours at another time. What is good to hear or know is that the studies that have been done and trials, and this was the seminal trial that was published in hydroxyurea, a multi-center study in patients, showed that there was a significant reduction, not just in chest crisis, but also in complications like chest syndrome. And that study was in adults. Later on, Baby Hug study showed that also hydroxyurea is effective in children and also safe in children. And therefore the FDA has approved hydroxyurea, not just for treating adults, but also children with sickle cell, and for the patients who tolerate it and also comply with it, because it's a long-term treatment of capsules every day. There can be a significant improvement, making the condition milder than it was. So I've already talked about that. There is an issue for most patients who come to clinic and discuss hydroxyurea. They're worried because obviously it's a drug that's used in cancer patients with some information in the literature that it may cause cancers later on. There's also a big issue amongst men with young adults and young males going into adulthood about the possibility of infertility. And all I will say here is that in young adult males with sickle, they've been looked at, their sperm counts and fertility has been looked at compared with hydroxyurea. There are a number of studies. One thing we do know is that from the sickling, the chronic sickling itself and anemia, males with sickle do sometimes have reduced infertility anyway. So there is not a clear evidence that hydroxyurea on its own makes this much worse. So what the advice I give to mothers who bring their boys is that those who have a severe phenotype already, those who are being admitted to hospital more than 3 times a year with severe pain crises, those who've had acute chest syndromes, and those who have definitely had a stroke, if they cannot have other definitive treatments like exchange blood transfusions or stem cell transplant, then for me and for most of my colleagues, I think that a trial of hydroxyurea is definitely something to think about. And also you can bank sperm, so that's for a conversation for another time. So the other thing is addressing the elephant in the room, which I've already alluded to, the stigma of this condition, a condition which basically is inherited, a condition in which, yes, sometimes people say, well, why, if they both knew they were AS, why did they go on to have children? And what I say is, you know, I don't think that a lot of us can actually be in control of who we meet, who we fall in love with. I mean, I, for one, met my husband when I was in primary school. We were in the same class from when we were 5 to when we were 11. And although, no, that was not a turning point for me, because obviously genetically I was taller than him, he was faster than me, and so on at that time. But, you know, I think these are the kind of things that we have to talk about and be realistic about. We have a huge incidence of the sickle gene in our population, as I've discussed before. So the likelihood, like for example, with my husband and I, when we were in a class of 30 people at that time, I know we had 2 children who died from complications of sickle when I was in primary school. I'm sure that almost another half of the class were probably carriers with AS. So the chances of meeting, falling in love with somebody who also had a carrier is quite high. So, but yes, we do need patient awareness. Yes, patient support groups are most important here. And also the impact that government will have, just like the National Sickle Cell Act had, in improving the way that patients live their lives and are treated by their employers and so on, will make a difference to patients. But the big thing is we need to discuss this condition. We need to take away the stigma. So moving on to the recent advances, this slide is just to show that there are a number of the 4 main ways in which we can tackle sickle. And all these ways have now, in the last 10 years in particular, there's been a lot of work that's been done in trying to modify or cure this condition. A lot of it has come about by the fact that we now understand more the genetics and the genomics associated with sickle. We now know that the gene that switches from fetal to adult hemoglobin is called BCL11A, and that could be a target. So going on from the theme of the talk last year about genetics and genomics, and now to show you that this is actually in real time making an impact in a clinical situation, particularly in sickle cell. Now, lots of patients come to my clinic and they've already had friends where they've discussed what's a transplant, what does it look like? And I'm not going to steal Iji's thunder, because I know she'll talk to you about that a little bit later. But just to say, because most people think that this is a solid organ transplant, that it involves surgery, when actually it doesn't. We can get the stem cells from a brother or sister who are fully matched. That's the best way. But there are other ways of also getting stem cells for transplants for sickle. And more, the use of what we call a haploidentical match, because sometimes the patient will match just with the parent, can also help, because with transplantation in sickle, you do not need the whole bone marrow to become AA for you to actually get the benefits of the transplant. It's something we refer to as mixed chimerism. So even if we have just 50% of the S taken away, then you're like AS and you don't have any problem. So it's quite an exciting time. And this is just to show that, yes, we collect the cells from the donor at the top, We have to give the donor chemotherapy and radiotherapy to wipe out their normal bone marrow with the S, the patient, chemotherapy and radiotherapy to wipe out their normal bone marrow. And we basically transfuse the stem cells. So it's like a blood transfusion. It's not, just to show that it's not surgery. And this is another cartoon showing that. So that's the donor on one side actually giving the stem cells that comes off that exchange blood transfusion. We take out the blood, we spin it down, we take their stem cells, and this is the patient receiving the stem cells. So it's not that simple. There are obviously a number of steps that go in between, but that's essentially what it's like. Now, I'm pleased to say that in the UK, having had lots of discussions about whether transplants should be funded, there are now a number of studies that show that stem cell transplants for sickle are very helpful, can be done well, as long as it's a center that's doing them all the time. And the results in the majority of the centers that do them all the time have success rates of over 90%. And therefore, recently, NICE and NHS England have now approved the funding of stem cell transplants for adults with sickle cell who obviously fulfill the criteria, particularly patients who've had strokes or acute chest syndromes. And so, like we discussed earlier, it's not that simple, as I said, and it's not without the potential complications, including fatality. But the two complications that are mostly we are worried about is where the stem cells that we give the patient from the donor attacks the patient's body, attacks their GI tract, attacks their skin, something we refer to as graft versus host disease. There are lots of transplant programs now looking at how we immodulate the irradiation or drugs, chemotherapy that we give so that we can reduce this, and that's helping more and more. Also, in some patients, the cells just don't take, okay? So it's something called graft rejection, and you can imagine how devastating that can be for a patient and their family, having gone through all the chemo and the radiation and so on, and the hope and expectations, and for some reason, the graft just does not take, something called graft rejection. So that is stem cell transplants, in the fact that you're going to take the cells from somebody who has a normal stem cells and you're going to give it to a patient with sickle cell to change their genotype. But more interestingly, and again, following with the talk last year about genomics, we now have a number of studies going on, and in fact, patients who are now being treated with gene therapy for sickle. And there are a number of ways of targeting gene therapy for sickle. One is to try and just remove that abnormal HBB gene, the beta hemoglobin gene I talked about. You cut it out, as is shown in the cartoon on the left-hand side, and you replace it with a normal hemoglobin, and then you give it back to the patient. So there's no donor involved here. It's all in that patient. So you take the patient's cells, you do the gene transfer, and you put it back into the patient using a viral vector. And there's some very, very good results coming out now. This is definitely something to look forward to for the future. So in terms of drug therapies, hydroxyurea, hydroxycarbamide has been licensed for quite a long time, both for adults and for children. And we've discussed the mechanisms by which hydroxyurea may help patients. And what more recently, in the last 3-4 years, we've now had a rush of pharmaceutical options for how we target sickle cell disease. I have to say that I remember going to the American Society of Hematology meeting in 2017-18 and being so excited, so proud that, you know, all these conversations are now happening in this condition that had been left for such a long time. And so none of these drugs are currently available easily, even in the developed world. most of them have been in the research setting, and they work in different ways, reducing the adhesion that the cells have to the blood vessels. Voxelotor, which is one of the more common ones now, which is helping to improve the oxygen affinity of the sickle cell, and crizanlizumab, which helps to reduce P-selectin adhesion. So this is just data from studies. L-glutamine is given as a powder, which is mixed with water, has been licensed mostly for children, and has been shown that it has an effect in reducing the number of painful crises. There's no evidence as yet that it may affect the acute chest syndrome or any other further complications, but in terms of painful crises, it's felt to be something that may be helpful. Apparently it tastes awful, so a lot of the patients, quite a significant number of patients dropped out of the studies. Voxelotor in the HOPE trial for sickle gave us some very, very good and hopeful data. It helps by improving the oxygen carrying capacity of the sickle cells. It's given in tablet form. And also it's been shown to increase not just the hemoglobin response, but also has been shown to reduce acute chest syndrome in a small number of sickle cell patients. So there is a lot of advances, a lot of improvements, and a lot of work that's being done now, which this slide shows. So, you know, starting with trying to modify the way we do transplants to make sure we get better at it, to make sure we reduce the complications like graft versus host disease, to try and find alternative donors, because as you can imagine, only about 20 to 30% of the population have a sibling that's fully matched. So we have to look for other ways of finding donors. I've already talked about the genetic gene transfers that are possible, and now a number of drugs, some already licensed and some still in phase 3 clinical trials. So to round off, sickle cell, the title was "The Future is Bright," but I also would say, well, or is it? Because yes, we do have new treatment options. We are working hard to see if we can reduce the complications and potentially increase survival for most of the patients that we treat. But I'm not sitting in Lagos at the moment, but I hope to be very soon. And if you're sitting in Lagos or anywhere in Nigeria or in Africa, you're probably saying, well, you know, I don't have access to even being tested to see whether my sibling is a potential donor. I don't have access to centers that are good. And I've already mentioned that the good results that we get are more from the centers that are doing these procedures all the time. There is no doubt that stem cell transplant for sickle is prohibitively expensive. So you're in the UK, even in the model where the NHS is now going to be funding for adults, stem cell transplants for anything, sickle, leukemia, you're looking at about 150 to 200,000 pounds sterling. And that's if you don't have any major complications. The new drugs that are available are not cheap either. And as we all know, the standards of care, even in the UK and in the US, were not uniform for most patients. Hopefully the guidelines will improve that. But yes, I am an optimist, and I was pleased to hear that Dr. Alakija was definitely an optimist. I am an optimist. I think that if we remove the stigma, and I'm been pleased to hear about the sickle cell warriors. I've been pleased to come to see patients more recently who talk about the fact that they've got sickle and are going about also helping with support groups, and we've got Iggy on today. I think that if we can implement all these guidelines that are now coming out, we've waited so long for them. I mean, the UK guidelines had not been updated for almost 20 years. You know, and now we're all standing at that line, and all we now got pocket guidelines that we can go about. And I think that if we can make this available in the country so that the care is optimal for patients, that would be great. I think we need to continue to empower not just the patients, but their carers, mothers with children who are constantly hospitalized, who are the end of their tether, and yet the medical staff that are involved are not listening to them, are not understanding what they're going through. I think there's a lot of work that can be done there. I think certainly I feel that we are in a position having such a high number of the incidents of this condition in West Africa and Nigeria should be at the forefront of collecting samples for biodata collection, banking them so that we can provide this for pharmaceutical industry in the future. One of the big questions I'm hoping that we can answer from collecting this kind of information, apart from treatments, is why is the phenotype so severe in one HBSS child compared to another? That sort of thing, which I hope will make a difference in how we manage them and support them. And I feel that also that we are at a position, having gone through the COVID pandemic and understanding just how important it is that we improve our healthcare. And I'm not a politician, and I'm not even going to go there, but luckily we have the Honorable Commissioner for Health and Dr. Akishete from the Sickle Cell Foundation. But I think it's time for us to have conversations about having national testing, antenatal, postnatal, and to consider stem cell transplants in the country. I think that, you know, as we're beginning to have more centers with irradiation, if we can also look at the issues regarding transfusion support, there's no reason why we should not be transplanting patients in country. So yes, I do feel that for sickle cell disease, the future is bright. And I want to thank, from the bottom of my heart, the team at DFAF. I think sickle cell disease's future is bright, partly for you coming to the table to have this discussion, but also for putting such an eminent panel together to discuss this, which, you know, helps to make sure that voices are heard and that together we can make these decisions to improve the care of a large population of our nation today and in the future. And I think that's my last slide. So thank you very much for listening. And I'll obviously be happy to take any questions that you may have. Thank you.
Thank you so much, Dr. Elebute. Wow. That was a very insightful lecture, and it is clear that there have been some amazing advances in the management and treatment of sickle cell disease. Like you said, the technology is there, but we do have some work to do. I believe that with lectures like this, raising awareness and calling for action, we can say, indeed, the future for people living with sickle cell is bright. Thank you so much again, and I look forward to exploring some of the insights you shared during the panel discussion.
Thank you.
It's wonderful to have a diverse and experienced panel. Thank you all for being here. I will start the discussion by briefly introducing our wonderful panelists. Professor Akin Abayomi is the Honorable Commissioner for Health in Lagos State. He is a specialist in internal medicine, hematology, biosecurity, environmental health, and human development. Dr. Annette Akinshete is a consultant public health physician. She is currently the National Director and CEO of Sickle Cell Foundation Nigeria, pioneering innovative means of ensuring that persons with sickle cell live normal, productive lives. Ms. Igwehi Aikomo, otherwise known as Iggy, is a sickle cell survivor and advocate who runs the EHEMI Foundation, where she documents her experiences and spreads awareness while working towards driving the statistics down for sickle cell in Nigeria. We have about 20 minutes or so for the panel discussion, 20 to 30 minutes. So I will urge the panelists to make their responses as concise as possible. I would like to direct my first question to Professor Abayomi. Honorable Commissioner, could you kindly provide an overview of the services currently available to sickle cell patients in Lagos State, perhaps making reference to the basic treatment options as well as the more advanced options that Dr. Elebute spoke about? Could you also provide an indication of the key challenges, if any, you're facing in meeting the needs of sickle cell patients?
Okay, thank you very much. Can you hear me?
Yes, thank you.
Okay. Well, first of all, thank you, Dr. Elebute, for that wonderful presentation. I didn't know you worked in St. Bartholomew's. I studied in St. Bartholomew's. So at least St. Bartholomew's produces great hematologists, it seems. And welcome. Are you back in Nigeria?
I'm on my way, and I have to say, I think I'm echoing now. I have to say that, and this is true, that when I started as a registrar, but I did come across some clinical notes with your name in it. So I think I followed you not too far behind, exactly, yes. I am on my way back, hoping to open a center which has been delayed by COVID. We'll talk about that, yes. I'm on my way home.
Okay. Well, I think this is the kind of thing that we want to hear when we have people coming back home and coming to exchange, the benefit of skills that have been acquired abroad. I trained abroad as well. I did a lot of work around the world. Yeah, but in Lagos, and basically Lagos-Ibadan axis, there's a very strong hematology cadre of expertise between the University College Hospital Ibadan, LUTH and LASUTH. There's a lot of hematology activity going on. And of course, sickle cell is almost our bread and butter as hematologists. I mean, if you go to work as a hematologist, on a single day, you're likely to see a number of sicklers in crisis. What we did in Ibadan and in some places in Lagos is to establish what we call sickle cell day centers, where you generally see hematology cases, maybe people on chemotherapy and things like that. But majority of the patients that you'd see in a day center are sicklers. Can you hear me?
Yes, but the volume is a little low.
Okay. Remote phone. I get it. Okay, I will try and increase the volume here.
You speaking up sounded even, better, much clearer. Yes.
Is that better?
Yes.
Okay. So I'm saying one of the things we need to do, we've already tried to do it, is to set up hematology daycare centers where people who have sickle cell can come in the morning. They are treated by experts who see this kind of thing every day. One of the worst things you can do to a sickler is keep them in the casualty, queuing up to be seen by the casualty call officer. As soon as they see them, then they start taking a history, and then start talking to the relatives. Meanwhile, the patient is rolling around in pain. I mean, what we do in daycare centers is before you even take a history, you give them a good dose of, be it a narcotic or one of the anti-inflammatory drugs. So I think that's the kind of culture that we need to promote here in Lagos and across Nigeria, where we have a very high burden of sickle cell. We have 27 primary healthcare facilities and a myriad of private hospitals that are all seeing a spectrum of sickle cell disease. Now, of course, there are many things, there are many aspects to managing a sickler. First of all, there's the infections that sicklers get, there's the anemia, there's the pain crisis, there's the complications, there's the psychotherapy, there's the family support. All these are very necessary holistic components of sickle cell management. And I think we need to look at sickle cell management in that context. You know, it's a holistic thing. Any family that has a sickler, particularly a problematic sickler, the whole family dynamic is affected. You know, and then especially if the sickler doesn't live long, ends up dying in their teens or in their early adulthood. I mean, it's such a shock to the family, especially because that sickler becomes the pet of the family because of the, you know, the frequent episodes of pain. You know, they're the ones that are pampered. They're the ones that can't do all the fun things. You know, they can't play football. Whenever they travel, there's a problem. You know, they're always popping pills. So, you know, we need to look at sickle cell in that manner. Now, of course, you know, we've got this new advent of drugs that are coming on the scene, things that are better than just folic acid and penicillin, which was the order of the day in the 80s or in the 70s. I think hydroxyurea has made a tremendous impact on sickle cell, and any other drug that, you know, elevates hemoglobin F, you know, or anti-sickling drugs. And then, of course, the advent of transfusion medicine, where we have opportunities for apheresis now and clean, uninfected blood, you know. And of course, you know, lots of sicklers often go to pharmacists where they get an injection for pain. And what used to happen in the past was, you know, some scrupulous pharmacies just use the same syringe over and over and over. And I've had a number of situations where sicklers contract either hepatitis or HIV, you know. So those are the kinds of things that are happening now. And I think we're improving the environment. We talked about bone marrow transplant. I think that's an important way to go, but it's up there. You know, there's so many fundamental things that we need to address first. You know, and I think every general hospital should have a daycare center where they see things like sickle cell. Sicklers don't have to wait. When we start thinking about genetic counseling, you know, these are the sort of things that we need to introduce. I think one of the questions you're going to ask me is around genetic counseling, but I'll wait till you ask me because it's a very contentious answer. So thank you very much.
Thank you so much, Professor Abayomi. My next question goes to Iggy. Iggy, firstly, congratulations on your successful stem cell transplant. Could you please share with us what life was like living with sickle cell disease, what the stem cell transplant process is like, what life has been like since the transplant, and what your main goals are in the field of advocacy for sickle cell disease?
Okay. First of all, I'm so honored to be here and to start off my journey with my sickle cell. I'm glad to say that growing up, my sickle cell wasn't so bad, and it definitely reacted to all the regular, like all the normal things to avoid. Like if I was too cold, I had a crisis. If I was dehydrated, I had a crisis, the very typical things. And I'm also glad because Dr. Funmi Alakija was actually my doctor, and I lived just beside Q Life Clinic. So I mean, any problems I had, I was running over there. So it's definitely an honor to have met her and to have been under her care. My journey with sickle cell was quite odd, I would say, because growing up, I didn't really have any issues with my sickle cell. But when I started university about 2 years ago, that was when I was 18, I started to see a lot of changes in my, even just the regularity of my crises. I would have them about every few months. Usually it was like once a year, twice a year, not so often. Then it would be every few months. Then I actually had to drop out of university in my first year because I was missing all my lectures. I was always in the hospital. I ended up missing exams. So it was just best that I took a break. And from that point, my sickle cell just got worse. I was having a crisis every week. I ended up being in the hospital every month last year. In some cases, I was there for up to a month, things like that. And I was that person that would have felt like I wasn't on the bad end of sickle cell. Growing up, I didn't feel like I had it bad, but it kind of changed as I got older. And I also, I mean, when I was 13, I ended up having to have my spleen removed. So I needed a sequestration. And that, I mean, quite common for people with sickle cell. I guess a lot of people with sickle cell wouldn't understand that, you know, you go see the doctor and they're checking how big your spleen is. So eventually mine got too big. I had to take it out. By the time, and like everyone else here or that knows about the bone marrow transplant, like I was very, I would say I was actually totally against it. The first time I heard it, I just didn't really want to do it. I was just scared of it essentially because it's definitely come a long way over the years. But when I heard about it, it was, you know, it has to be your sibling that's the donor. I have just a brother, he's 5 years younger than me. And, you know, they would talk about how if your donor has to give you, you know, their bone marrow, it would be quite difficult. It had a lot of side effects. And I was quite young then as well. So I was just like, no. But as I got older, I learned a lot more about it. Of course, it's definitely not the easiest thing to go into. There's like, it's one of those things that even till now, I know a lot of people are scared of it, but having done it, it definitely has changed my perspective on the whole thing, because to any sickle cell patient that just feels like they want that change in their life, I definitely recommend, because for me, it was more my last option. I was on hydroxycarbamide as well. It didn't really work for me. And I know that's, you know, dependent on the person, but it didn't really work for me. I'd been on it for about 2 years on and off. It just wasn't the thing for me. I was on constant painkillers, like it was really intense. I actually experienced hyperalgesia, which is when your body essentially stops reacting to certain pain medications. So I stopped reacting to morphine. Morphine. My pain couldn't be treated. They had to try a lot of different painkillers. And, you know, my crises were getting more frequent. It was really just so hectic that, you know, my family and I were just like, okay, bone marrow transplant, it really just seems like what we need to try right now. And I had my transplant in the US. I actually relocated, because I live in London, so I relocated to Nashville, Tennessee for 6 months. And my mom was actually my donor, so she was a 50% match, and it was very successful. As you can see, I thank God that I'm here, and I'm here to live and talk about it. And it was, I would say it's intense. That's, I think, the one word for the transplant is definitely intense. It is something that you definitely need your time to think about. As much as I recommend to everybody and anybody, I definitely would say it's something to think about. You need to really talk about it with your family. Even, you know, with yourself, you need to really know how much you're willing to give, because the chemotherapy, as you see it on TV or anywhere else, it is intense. It is not easy. Me having to relocate with my mom, you know, it really was tough, because with her being my donor as well, she definitely had to have a surgery just to give her bone marrow. And for me, I mean, if I just break it down into how long everything was, it was chemotherapy for a week. Then you have your infusion. So the essential stem cell transplant is just a few hours in the day. You just have like a blood bag. They give you the bone marrow, and that's really it. And then I was in the hospital for about 34 days after that. So, you know, altogether, like, I mean, in terms of recovery as well, 6 months is a really long while. It's a big strain on your body. I lost about 10 kg during the whole process. And, you know, the whole thing with your appetite, just everything that comes with the package is something that takes a lot. And considering, you know, we already have sickle cell, it's a big strain on the body. But honestly, like, I have to say that sitting here today, having recovered, I don't have any pain anymore. I think the change is so drastic, but it is so amazing because back then I definitely did feel like I couldn't have carried on another year with all the pain I was going through. But today I'm looking to start university again in the next few months. I don't struggle with any pain whatsoever. It's quite amazing. But the one thing I definitely have to say is the recovery is tough. It's tough in its own way because, you know, you essentially don't have sickle cell anymore, and you kind of have to adjust to what is a normal life. So, you know, I've gone from, I can't really participate in sports. I never used to go out when it was cold. I always had to take things easy. And now maybe if I go out and it's quite cold, I kind of expect to have a crisis, and I'm just kind of very wary of myself. And you find that like your body as well is very used to that, so you kind of have fake pains, what they call phantom limbs. And it's a mindset type of thing, but it's also the whole recovery journey is tough because I guess in today's world, there aren't a lot of people my age, I would say, that have done the transplant as well. So finding support groups is quite difficult. A lot of what you do with your recovery is essentially by yourself. So that is what I would say is really hard. Just looking at the most important thing, and I would say regardless of a transplant, with or without a transplant, looking at our mental health is very important. As someone that has had sickle cell, someone that has now had the transplant, focusing on your mental health is a very important thing, because coming out of the transplant, I just felt like I don't really know who I am anymore. Like, you know, your body changes completely. You really have to learn yourself again. The food you can eat, the food you can't eat. It's like basic things like that. It's like a baby, but in a grown woman's body kind of thing. So it's tough, but honestly, completely, it's just so, it's worth it. For me, it really has been worth it, because even with the risks, and that is definitely to say there are risks, but like I said, it's just about you. And at that point, I was ready to really go for that, because the life I now have is so amazing. I can never stop thanking God. And I guess living that life and having the transplant, that's why I've always been quite focused on helping other people around me as well, because growing up, I didn't really have anyone to help me with my sickle cell or help me understand my sickle cell. And that's to say, because my dad actually had sickle cell as well, but he passed away when I was quite young. But growing up, I didn't really know, I didn't have friends that had sickle cell. There were no kids my age that knew what sickle cell was. So it wasn't really the topic to talk about any other day. So I started my foundation, the DFA Foundation, back in 2018. At that point, and that was when I was in university, so when I really started having complications. And at that point, I really felt like people don't know what sickle cell is. And if anything, I would like to be the example. I would like for people to look at the content I put out, to look at my life essentially, and understand what a lot of people are going through on a daily basis. So if it's the DFA Foundation on Instagram, but I'm sure I could share all this information later. And you would just basically see pictures, videos of me just talking about my experiences in the hospital, my experiences at home, handling day-to-day life. And my main focus with my foundation is I really want to help educate people, especially in Nigeria, because living in Nigeria, I've done a bit of work with different people in different places, and you just find that people don't really understand what sickle cell is, especially even people with sickle cell don't essentially understand what is going on in their bodies, with their bodies, even family members. And it is definitely really hard. It is not easy at all. But then again, I feel like, we have the responsibility to help ourselves. We have the responsibility to step up and educate each other and help in any way we can. And that is what I hope to do. I hope to help people who end up helping other people later on. And, we just wait to see what the future holds.
Thank you so much, Iggy, for sharing your story and your journey. That's an incredible testimony. And also for highlighting the mental health aspects, which undoubtedly loads of sickle cell patients also deal with. My final question, before we go to the Q&A sort of part and ask more questions to our panel and Dr. Elebute, goes to Dr. Annette Akinshete. So Dr. Elebute pointed out that the best approach for the management of sickle cell disease is a multi-pronged one, requiring care and intervention from healthcare professionals, family, community, and government. Before we wrap up today, can you tell us a bit about the role of the Sickle Cell Foundation in Nigeria? Any other sickle cell foundations in Nigeria people should be aware about? And are there any successful collaborations between the various organizations and the government?
Thank you very much, Tony. Thank you so much. Thank you, Iggy, for that insight, powerful testimony. And I'm very proud to have been a little bit, part of that journey. Thank you so much. I look forward to seeing you. Dr. Elebute, thank you for that comprehensive, also very insightful presentation. I've learned a lot. There's never a time when you say you know everything about sickle cell is impossible. And the fact that you said the future is bright, I buy into that. You're not the only optimistic person here. We're very many. And I need many more persons to come on board and be optimistic in this area, in this space of sickle cell, where there's a lot of gloom and doom many times. When I was discussing with you long before this this lecture, I first said to you that I ventured into the sickle cell space when I was a young doctor, when Professor Kuti was Minister of Health. And for the first time, they were putting together a kind of structure for sickle cell control in Nigeria, the very first time. So I was a desk officer in the Ministry of Health for non-communicable diseases, under which, of course, we have sickle cell. It was Professor Kuti who included sickle cell, because globally, it was a global move, but globally, it was hypertension, diabetes, cancers, not sickle cell. It was Professor Kuti being a pediatrician, and like Dr. Elebute mentioned, when we were medical students, I think sickle cell was basically a pediatric illness. So this is what he saw every day at clinic. So he felt Nigeria being the country with the highest burden of sickle cell in the world, we needed to insert sickle cell amongst our non-communicable diseases. So there was a non-communicable disease control program in the Ministry of Health. And the way it was structured or planned was that down the states and then to the local government level, there will be sickle cell programs and desks, non-communicable disease programs and sickle cell desks at various levels. We did a huge survey at the time in 1989 across the country, the first in Africa, in fact, the National Sickle Cell Survey, National Non-Communicable Disease Survey, including sickle cell, where we went all over Nigeria to determine how much of non-communicable diseases we really had. And it was a community-based survey, the first community-based survey. Most of the data we have come from hospitals. And at the time, I must tell you that when we went around Nigeria, it was difficult to have people admit that their children had sickle cell. We had to use the language of the people to say, is it Abiku, depending on where you were, or is it Obanje, or your neighbors will whisper to you that in that house next door, there's somebody with sickle cell. But I think over the years, with better treatment protocols and the fact that they're living longer now, we have, when I go into the communities now for surveys or community outreach programs, that's what I would call name recognition. Even the word, the phrase sickle cell, they know it. You'll be surprised. And even in the rural areas, they talk about sickle cell and they bring out their children now. So I think in the space of 3 decades or so, a lot has happened in that area. There's a lot to be done more, particularly in the area of advocacy. Having said that, government started something, but I think the way things have happened, because I've worked in the public sector, in the public health space. I was director in Ministry of Health for non-communicable disease and also for HIV and AIDS. I worked also in the United Nations in New York. So I know that when you want to push an agenda, it's best that you are at table. There must be somebody seated at table. The sickle cell agenda has suffered a lot because it's really something that at national level, at global level, it is not something that affects everyone. So it was for us, it behoved us in the African region, because we pushed African the WHO African region to work with us to push for what we call World Sickle Cell Day, celebrated in June the 19th, with a lot of lobbying and negotiation at the United Nations. But today we do have it, but it took years of lobbying. Normally, it take that long, but because it's something that doesn't affect the rest of the world, it took us a long time. But now back to what's happening in Nigeria. It's sickle cell has clearly fallen through the cracks. Generally, because I can compare both. I was director for HIV and AIDS. I was the director for non-communicable diseases. There was a lot of support for HIV and AIDS because of the global, the fact it was a global agenda. We didn't have that kind of support for NCDs. And within NCDs, certainly sickle cell suffered the most, fell through the cracks. So when I returned from New York, I pitched my tent with the Sickle Cell Foundation Nigeria, because I felt there's so much people are doing in the area of HIV and AIDS. So let me go where I am needed in terms of advocacy, because I have the public health background, and I've seen both sides. And so Sickle Cell Foundation Nigeria is a not-for-profit, NGO, and I think what it has done is picked up the slack from where government has left off. There's a huge yawning gap there where we haven't seen comprehensive policies and even legislation. These are tools that you can use to ensure that you take care of business in terms of sickle cell control, from prevention to treatment and care and support and even cure. So Sickle Cell Foundation Nigeria fill that space. In Nigeria, there's the number of NGOs who work in the sickle cell space. But what we have done, because we have a grand name, is bring them together under a coalition of sickle cell NGOs. So at least we speak one language in terms of the message we're conveying to the public. But we also have established the National Sickle Cell Center opposite from Luth, across from Luth in Idiaraba. And that's the first comprehensive center for sickle cell in the whole of Africa. And it addresses everything relating to sickle cell, including research. And I'm pleased to say that we are establishing the stem cell transplant center, a comprehensive stem cell transplant center. It's near completion, and it's going to be, I think we'll take off by January of 2021. I think the COVID-19 certainly set us back. But the way we're working now, and we're working in collaboration with Lagos University Teaching Hospital, it should be up and running by January 2021, by the grace of God. And but just to let you know that besides that cure, there's so much that's going on at that center. Dr. Elebute alluded to the big problems that we have in the area of sickle cell acute chest syndrome. We see children. I'm very fascinated when I see those children coming in at death's door. But we have an exchange blood transfusion unit that it's automated, and in very short order, within a few minutes, the children are running, almost ready to jump off the couch to play, because it makes such a difference. That's an exchange blood transfusion. The other big issue is stroke that they have. So what we do is mobilize all the sickle cell clubs across, not just Lagos, across the country, to be sure that children between the ages of 2 and 16 access a transcranial Doppler scanning. We have a transcranial Doppler scanning unit, and we do that for those in the Lagos area. But we also do training across the country in the 6 geopolitical zones for doctors and nurses, so that not just radiologists and radiographers can actually carry out that procedure. So scientists are trained to be able to do that. So we have greater access to that, and then to also raise awareness about the fact that stroke is a possibility when you have a children with sickle cell. And in fact, clinicians will tell you that once you have a child with stroke, invariably that child probably has sickle cell disorder. And I'd like to mention that language, we try to change language also, to alter languages because of stigma. You notice we are moving away from disease and talking about disorder. We don't talk about sufferers. We don't talk about sicklers anymore. We call them warriors. In fact, we work with the sickle cell community as a group, borrowing from the HIV and AIDS, for instance, playbook, where they talk about persons living sometimes and thriving with HIV and AIDS. So we talk about persons living with sickle cell. So we're doing that now, and I'm glad to say we're working with government. Government may not be able to fund in terms of money, but we for instance, at the Sickle Cell Foundation, have embedded clinics, dedicated sickle cell clinics. So they don't mix with other patients, and they're treated immediately. They're seen within Massey Street Children's Hospital in Lagos and Lagos General Hospital, and we're doing the same across a few other general hospitals in Lagos. We're doing the same also in selected states in the country, Delta State, Edo State, Kano State. Kano has a huge clinic. 1,000 patients are seen in a day in a dedicated sickle cell clinic. So in our center, for instance, however, we also have a daycare clinic where patients are brought in, cared for in crisis before being referred. So I think we're picking up the slack from government. At the end of the day, we're still advocating and holding government's feet to the fire, because Nigerian government has signed a number of conventions and treaties that, including, for instance, the SDGs. If you say you want to work on SDGs and reduce target number 3, reduce goal number 3, reduce child mortality, then you must address sickle cell, because indeed it provides or presents us with low-hanging fruits to be able to take care of you, because if you tackle sickle cell, you reduce child mortality a lot. So because of time, I think there's so much one could have talked about. In terms of questions, before I forget, I would like Dr. Elebute to please differentiate between gene therapy and gene editing before we close this. Thank you very much for your attention.
Thank you so much, Dr. Alakija. Thank you very much. The foundation clearly plays a huge role in advocacy and research. Thank you. Many thanks to the panelists. It was an extremely informative session. We've received so many questions in the question and answer box, and unfortunately we only have 10 minutes, pretty much 10 minutes left. We'll try to cover most of them, but all the questions that we can't answer, we will get answers to and email it to each and every attendee, okay? Just to go back to Dr. Elebute, really quickly, what treatment guidelines are followed? This was one of the questions. What treatment guidelines are followed in Nigeria? Are there specific African guidelines at all? And is there a role for like herbs or other forms of treatment than just medication?
Okay, thank you very much. And first of all, I just want to say thank you very much to Dr. Alakija, and hopefully I'll have an opportunity to talk about gene therapy and gene editing. But to come back to your question, I don't think, we need to rewrite guidelines. I think that there's been a lot of work. I mean, the Sickle Cell Society guidelines that were published is over 100 pages long. Like I said, the American Society have written, and they've now written specific guidelines for the general care of sickle, but also particular complications. To my mind, I feel that we just need to implement one of these guidelines in country. I mean, I had a discussion with Yemisi Ayeni when we were hoping that this was going to be an in-person, face-to-face meeting. And, I'm still happy to try and contribute copies of the guidelines to, hospitals in Lagos. Also, my colleague and friend of mine, Dr. Moji Abubade, who actually did a lot of the sickle work when I was at King's College Hospital as a consultant, because I specialized in a very rare blood condition. But together we wrote a leaflet called Living with Sickle Cell, so a bit like Dr. Alakija referred to, and it's a small booklet, and I can share the soft copy with you. I do feel that before I share it, actually, maybe we just need to do a little bit of work, because there's been so many changes recently, but only about the therapeutic advances, and just to mention them. But the mainstay of how we manage sickle remains the same. And just because I did look in the question and answer box quickly, and yes, I did, there was so much to cover, but for the sickle patient in Nigeria today, like Iggy said, knowing your condition, being mindful of your condition, living your life, knowing that you have this condition. So being careful, I mean, obviously for children, it's keeping them warm, it's keeping them hydrated all the time, it's picking up on painful crises early and getting analgesia into them quickly. But on a prophylactic or preventive whatever, is folic acid daily. It's penicillin V daily for those who or the immunizations, pneumococcal, Haemophilus influenza. The immunizations are every 5 years. So those sort of things: folic acid, Pen V, immunizations, hydration, warmth. And when the patient has pain, quick painkillers into them, massage, and so on, it does make a big difference. So we don't need to reinvent the guidelines, but we need to implement some guidelines. And I think that's where we have to work together with the Sickle Cell Foundation and other to bring together guidelines that are already written and just, change the name on the front. I don't think anybody cares. I think what everybody's more interested in is making sure that all the teams that are involved with looking after patients are aware what is the best standard of care. That's basically what we want to do.
Thank you so much, Dr. Elebute. And in light of that, I would like to ask a question to Professor Abayomi. This is from one of our participants. Congratulations on doing a fantastic job with the public health campaign to destigmatize COVID-19. The person would like to know how do we get to that level with sickle cell? How do we get to, what can we do? What are the steps? Professor Abayomi.
Okay. I'll do that. All right.
You're on mute.
Sorry, while we give, thank you so much, Dr. Akishete. While we give Dr. Abayomi a chance to rejoin us again, I'd like to ask a question to Dr. Akishete. You had mentioned, sorry, give me a second. So you had mentioned that you're planning to start a new transplant center, and you'd mentioned some of the costs involved. Can you speak to, some people have sent in messages about the cost and concerns about that. Can you talk more about that for people who are living with this?
Very quick. Let me just add quickly that we have a pocket guideline for doctors and nurses. Of course, we pooled, like Dr. Elebute said, we don't reinvent the wheel. We used all available material that we could lay our hands on, guidelines from the UK, guidelines from the US. So now we have our own guidelines by Sickle Cell Foundation Nigeria in collaboration with the WHO AFRO. And now we've disseminated this across the country, and we're using it for doctors and nurses. And there's also one for other caregivers. Now, you were asking about a bone marrow transplant or stem cell transplant center. Okay, we're still working on the costing or the pricing, but whatever the case may be, it's going to be a lot less than what it is if you travel to the UK or to America or to India. India is a popular place where many of our doctors refer patients. So this will be locally available and accessible to our people in Nigeria, and definitely the costing will be made known to everyone in due course. If you just go to our website to be updated once we have the pricing, but we bear in mind the fact that it has to be affordable, and a lot of what we do is subsidized. We always reach out to corporate organizations, well-meaning Nigerians, to subsidize, so we're able to give access to particularly indigent patients. Does that answer the question?
Yes. Thank you, Dr. Akishete. Is Dr. Abayomi, Professor Abayomi, are you there?
Yes, I'm here.
Hi, thank you. So we were just asking, one of the questions from the Q&A was saying congratulations on the great public campaign, regarding COVID-19 and destigmatization of that. What can we do to get sickle cell disease to that level, sickle cell disorder, sorry, to that level?
Well, I think, first of all, we need to have a mass campaign on any newborn child should automatically have a genotype. I think that's just to establish your baseline. And then, you know, from there you can now, I mean, they did that in Jamaica, for example, and every child that was born in Jamaica had to have their genotype done. It was very easy to set up cohorts and understand how sickle cell operates in your environment. And then we can you hear me? Yeah.
Yes, sir.
And then we can define the treatment options. We also, if you know you're a carrier from child, you know, and everybody knows what their genotype is, you're less likely to be dating someone that's a carrier as well, which is also reduces the chances of you having a sickle cell child. And then, you know, you just give it publicity. I mean, sickle cell is so common. You know, we just have put it to the back burner. Nobody even wants to talk about it. If we just give it a bit of public awareness, you know, have some sickle cell drives, if everybody is having themselves their genotype assessed, you know, then it just makes it, you know, just like in the Mediterranean, everybody's talking about thalassemia. So here in West Africa, we should be talking about sickle cell because, you know, 25% of people are carrying the gene, 4% have the disease. That's a lot of people, you know, and you can imagine the disease burden in community. And we're just neglecting that, and we're not paying much attention to that. There should be a sickle cell clinic in every general hospital and in every private hospital that's seeing more than 50 patients. You know, you should have a sickle cell facility, you know, with everybody linked to a good blood transfusion service and a good laboratory, because, you know, you can't just use hydroxyurea. It's quite a potent drug, you know, and you need to be able to understand how to use it. You know, it can cause severe myelosuppression. And sometimes you don't get the benefit out of hydroxyurea because you're not using enough. You've got to titrate the level of hemoglobin F with your neutrophil count and your platelet count. You're looking at the myelosuppressive extent and balancing that with the beneficial effect of raising another type of hemoglobin in your blood, you know, which makes life easier for you. And if you can't do that titration, you need a good laboratory to do that. Not every laboratory can do that. You know, it's quite sophisticated stuff. So I wouldn't advocate that people use hydroxyurea without expertise, knowledge to support it. You know, and those that know how to use it, they can use it quite effectively. You know, majority of patients respond to hydroxyurea, those that are complicated. I know some don't, and we heard Ms. Ikomo saying that she didn't particularly benefit from hydroxyurea. But I know a lot of people whose lives have been transformed by hydroxyurea. Without a doubt, you know, it makes a difference in a lot of people. So I think that's just what we need to do. We just need to keep at it. All the hematologists on this platform, Dr. Akinshete, Professor Akinshete, Dr. Elebute, we just have to keep at it, you know, spread the message. And I like the idea. I was listening to your talk, Dr. Elebute. Maybe we need to put some laws in place, you know, that mandate screening at birth, and some of the things that you talked about in your management, you know, those are, and that made a difference in America. You know, once those laws kicked in, it gives executive power to the kinds of policy shifts that you want to make. So I think that's just what we need to do. You need to have a powerful lobbying voice.
And fortunately, we have all the people on the panel and Iggy with her foundation as well, who are going to feed into that. Last question, because we really are out of time and we want to be punctual. Dr. Elebute, what advice would you give for couples who are planning to have kids, whether or not they have their status?
Okay, so you can't ask that question by saying whether or not they know their status, because they should know their status. That's where we should start from. And I'm very, very grateful to Professor Abayomi for talking about, legislation, because legislation is going to be important if we're going to make a difference and to help the foundations, Sickle Cell Foundation and other organizations like that push all these things forward. So I think, by the time I left medical school, I was coming to the UK to do my postgraduate studies. There was already talk about doing tests on newborn babies. I think we need to implement those things with the guidelines. I'm not saying we should just implement what is being done in the UK or the US. We have to write ours. All I'm saying is there is already a body of work. We need to use that body of work and make it into Nigerian guidelines. So we need to have legislation behind us. We have to have the guidelines. We have to have the lobbyists and government. When it comes to people, to young couples, they need to see a specialist who, we have joint clinics between the obstetricians and geneticists and counselors. But, I will also say that, it's all right for people to say, well, if you know your AS and you know your AS, you shouldn't get married, you shouldn't have children. But, that is not something that's going to be realistic, right? If you've met your life partner and you're both AS, I remember, personal story, age 42, decided falling pregnant with my last child. And remember the questions about having Down syndrome testing. I chose not to have the test. It's a very personal thing. So, but I know I had the conversations, I sat down, I went through it and so on. And then you make your decision, knowing it's knowledge is power. Knowledge is power. And also, like we've already addressed today, there are a number of possibilities for warriors with sickle cell. I'm not going to get annoyed. I must get on Dr. Akisha's train. There's a new things that are happening. This is a condition that is inherited. There are many other inherited conditions. There are even cancers. Angelina Jolie took off both her breasts because she comes from a family that had a gene for breast cancer. No one said, don't talk about it, okay? All right, so yes, it's about them having access to people who have the expertise to guide them, to tell them all the options that they have, but to also support them if that's their decision to have it, and support them if they decide that actually, no, this is not something that they want to have. But we have to have the testing in country available. We have to have the legislation and so on, so that we can provide a service that is available to most people. It's incredible to hear what the Sickle Cell Foundation are doing, but I will say, for example, I had a question yesterday asking me where a newborn child could have a test done. And I asked 7 people before, even in the medical sphere, before I got a right answer. That should not be happening in Nigeria. We should know. There should be places in real time. We have a high incidence of this condition. We can't pretend that it's not happening. And we must be supportive, and we must be positive. And we must make sure that care and counseling and the mental health support that Iggy was referring to, that is a big, big issue with sickle cell. We didn't have time to go into that today, but we need to make sure that we are having those conversations. And for everybody who is a sufferer, warrior, and their families who are listening today, and to people who've never heard it before, this is a condition that's inherited. There are many inherited conditions out there. It's not a communicable disorder. We have to manage it in a positive way. Thank you.
Thank you so much, Dr. Elebute. We do have a lot of work to do, but as we mentioned, and loads of people mentioned, the future is bright. There are options. Many thanks to all of you for your excellent replies, and thank you so much for sharing your rich depth of knowledge with us. Please note that the link to today's recording will be sent to all those who registered for the webinar, along with a short feedback form. We would appreciate if you could kindly return the completed form to us as soon as possible. It will only take a few minutes. Any other questions can be sent to info@dfafoundation.org. All the questions, there were so many, and I really wish we had time to go over everything, especially with our fantastic panel and keynote speaker here. But we will answer all your questions and we will email them out to you. Okay. We are now coming to the end of this event, and I would like to call on a member of the Board of Trustees, my dad, Dr. Adetokunbo Alakija, to give the vote of thanks and the closing remarks. Dr. Alakija.
Oi, thank you. I will digress a bit. I wanted to give a straightforward vote of thanks. But when Funmi and I met in medical school, of course, we fell in love. Boy meets girl and falls in love. And we ultimately got to know we're AS because we're in medical school, we're doctors. But we still went on to marry. We decided to take that decision. I will marry. At that time, there were some promising tests in the UK, and we did one test where they take a bit of the placenta or whatever and determine. But that test led to an abortion. So we made up our minds that we will not do any more tests and we'll just have our kids. We thank God I want to have my 3 lovely daughters now if we decided not to marry and we went our separate ways. So it's a difficult decision. Everybody there takes their decision how it is. You pray to God and you move on. With that said and done, I will now go to my thanks, vote of thanks. Well, to all the people out there, all of you, I'll say thank you all for participating in the second Dr. Funmi Alakija Foundation Annual Medical Lecture series in 2020, the year of COVID-19. We didn't want it this way, but it has happened. And this is a virtual one for this year due to COVID and unwanted guests. We hope 2021 we will not see COVID or we will have conquered it. And I'm glad you're all alive and well to witness this lecture. Much appreciated. Now, the first DFAF lecture was on understanding the new age of genomics, like the chairman said, and it was brilliantly delivered by the distinguished Professor Akin Abayomi, the Honorable Commissioner of Health, Lagos State, on the 18th of April, 2019 at 10 a.m. or thereabouts. And we had some distinguished panelists then. I have to mention them, Dr. Jide Idris and Dr. Biodun Aluko. So we thank those panelists. We thank Prof for really making it a thriller. It was a thriller, really quite interesting. And this has been just as interesting as well. It's a pity we wanted it to be not virtual, but God knows best, and we are here today. Now, the DFAF board felt that the appropriate follow-up topic will be sickle cell disease. We took some time to deliberate on it, and that the future is bright. That was just added on. It was an add-on. I mean, why should we debate sickle cell disease? It's debated over and over. It's a common disease here. And it's proved to be a very good topic. And you can see how nicely it blended and was delivered with the genomics. And for those of you who did not see Professor Bayomi's lecture, I believe when it's being sent out, this current lecture, maybe that can be sent out as well, so that you can see both the current one and the first lecture. And it will help you understand where we are coming from, where we are today, and probably have an idea of where we want to go at the third, fourth, and other series. Now, Nelson Mandela said, it always seems impossible until it's done. So sickle cell seems impossible, but it can be done, and I'm sure it will be done by Africans in Africa. The fact that we are all here today talking about how to improve the quality of life of the several millions of adults living with sickle cell disease in Nigeria, when less than 5 decades ago, most people with sickle cell disease did not live past childhood. is a testament to the power of God, science, and advocacy. Dr. Elebute talked about therapies that can cure sickle cell disease, and Iggy is here with us today. Iggy, we thank God for your life, and I'm glad you were Dr. Alakija's patient, and I'm glad you enjoyed your time with her. And today, Iggy is a living testament. This is truly a remarkable time, and I cannot wait to see what the future holds, especially if we all commit to taking action. I'll take a bit of time. Normally, I don't talk long, but Dr. Funmi Alakija died from a very debilitating disease which has no cure to date, and that is ALS. Some people call it amyotrophic lateral sclerosis. Others will call it Lou Gehrig's disease or motor neuron disease. It's a motor neuron disease. And it's a nervous disease that weakens muscles and impacts physical function. Nerve cells break down, which reduces functionality of the muscles they supply, and the cause is really unknown. They say it's an autoimmune disease, but the causes are unknown. Why have I gone down this path? We all saw Dr. Alakija decline over 7 years, and she fought the good fight. You know, but ALS, we all knew gradually it would take her, and it did. So part of the foundation is to duty, and because of that, is to talk about life in general, life-saving things going into the future, how we can help humanity. And that is part of why the foundation was formed, looking at modern science techniques and hopefully helping as we move ahead. Now, friends and family decided to set up the foundation in her honor to fulfill her dreams and desire for humankind. That is to create a healthier environment where all can thrive in good physical, mental, and spiritual health, being comfortable, being happy, having social, being prosperous. You need good health. Without good health, you can't be prosperous, and having a sense of purpose. She believed and trusted in her God absolutely and prayed before any task she did. So that was her motive, her motto, to pray and then act. To sum it all up, health promotion in this sense, health enables social, economic, and personal development towards the well-being of all human beings. So we all pray for good health. Now, there's an interesting term that has been set up or said recently by, you will know who the person is, I won't mention names, not to seem to go political, but it is warp speed. And this warp speed has come up because of COVID, what COVID has done to the world, and we need vaccines urgently to conquer this COVID. Well, those of us that love and follow the Star Trek series know that if you don't have a warp engine, you can't go at warp speed, or if your warp engine is damaged, you're not going anywhere at warp speed. In Africa, unfortunately, our warp engine has been damaged. We don't have warp engines, or we never did, or we don't have. So what are we going to do? Also, when you have warp speed, you have to be sure of your trajectory, and it must be well calculated, or you may end up in a supernova. That means your space jet moving that will just end up in a star, or an exploded star, you're dead. So in Africa, which Nigeria is a part of, we don't have warp speed technology yet, but we can use the little things of life to make the difference. Go for incremental growth and improve the lot of our citizens. So tiny things could help, tiny ideas. We have to think of little ideas, which is part of the foundation's thoughts. We don't need huge scientific things to make life easier for people. And funding is sparse in this part of the world. So most of us have adjusted our working lives to well over 70 years, so we are working longer than planned. And sickle cell disease is a health burden on families and states, and will need the support of all Nigerians in better understanding the disease and working towards its total eradication over time by education and scientific research. Funding for sickle cell worldwide, as has been discussed, is quite little compared to some less common diseases where huge billions are spent. And so it is a challenge for Africa and the Black race in general to come up with our own solutions. Now, I want to thank Mr. Governor, the Governor of Lagos State, and the Honorable Commissioner of Health, and I thank God for his health. COVID did not take him. We needed him more than God needed him at this point, so he's staying with us. And they made me the chairman of what they call the Lagos State Health Management Agency, called LASHMA. And this is an initiative of the Lagos State government to make sure that all residents of Lagos State are covered by basic health care. So I'm appealing to everybody to look at this LASHMA, this thing, and try to join it. If you can join it as a family, you may have your own insurance, you may not want to come in yet, you can make sure your staff or indigent members of your family get in on the scheme. It helps. At 8,500 naira per person or 40,000 naira a family for 1 year, a family of 6, that means husband, wife, and 4 children, they are covered. And things like this sickle cell management, and it builds the health fund, you know, so it helps. So we should all get on the Lagos State Health Insurance Scheme. Let me wrap up now. I have digressed a lot. And I thank the speaker, panelists, and moderator for jobs well done in educating us on the subject. Thank you, Dr. Elebute, for the wonderful lecture and for sharing your knowledge with us. To all the panelists, Professor Akin Abayomi, Dr. Annette Akinshete, and Ms. Igi Aikomu, I really like your courage, Iggy, to come and speak. And most of us have to speak out. We shouldn't hide things under the dustbin. We shouldn't lock our kids or family members away. They should be brought out, and we should make the environment comfortable for them. And I thank you for your different perspectives that have shown us that the future is indeed bright for individuals living with sickle cell disease. I want to thank the organizers and board members of DFAF. I thank the Governor of Lagos State, Mr. Babajide Sanwo-Olu, for his support and encouragement of all innovative and positive ideas in the state to date. Lastly, but not the least, I thank you all the listeners and viewers for taking out time from your busy schedules to be a part of this important lecture and discussion that has taken place today. Thank you for your time, support, and encouragement. We look forward to seeing you in 2021 for the 3rd DFAF Annual Medical Lecture. And please, suggestions are welcome here at this point for the next one. I know we are not perfect, so just bring any suggestions towards the next one. Stay healthy, stay well, and stay fit. Please wash your hands, social distance, and wear a mask. Thank you.